ago, just back up to this slide, whatever slide number this is, with in chapter 15 with the uterine activity. So we'll start with that. As for your test, you may or may not have noticed a 2-point increase in your score. It wasn't done until yesterday evening. And that was for the question question about hyperemesis gravidarum, the patient was vomiting every day, which acid-base balance would you expect to see? So what you saw were 4, sets of, blood gases and what you had to pick the one that was metabolic alkalosis. So I know you are, even though you did do a review recently with technique, I know you're probably a little rusty on them. So if you got 2 of them had an acidotic pH, 2 of the choices had an alkalotic pH. If you at least got the alkalosis side, which all you had to look at for that was pH, I counted it right. So I think about 25% of you chose an acidotic answer. Therefore, you did not get that question counted right. But there was a whole lot of people that were split between the 2 alkalotic answers. So I counted it right if you at least chose a pH of 7.5. So there's one other question that I'm looking at, but I just have not had a chance to dig into the book and do some research. And that is the one about, that question has a filamentous insertion of the cord, spontaneous abortion. So I'm looking at that, and I'll try to do that after class today. I just have not had a chance to do it. I've got a couple questions about it that I need to look at before I can make a decision on it. Other than that, the test was pretty clear cut, and there weren't a whole lot of much controversy. The average score before I made any adjustment was 82, so that's really not bad. We like the scores to be somewhere between 80 to 82 and 85. That's kind of the middle of the road. There actually were 6 A's, 6 C's, and everybody else had B's. So that's within the A, B, and C grade. That's a perfect bell curve. I mean, it's not a bell curve if you take it all the way up to F, which that's okay. We don't want to do that. But a perfect bell curve between the A, B, and C numbers. So I think it was a good test. You guys overall did well. I've had students completely bomb that test. I would guess. If I was guessing, I'd say it's probably maybe the hardest test you take this semester. A lot of heavy content on it. So you guys actually did fairly well. Real well, actually. So good for you. And in addition, some of the materials before spring break, so you had to kind of pull that back in. So I have heard several comments that the questions that we worked on the day before the test, the questions that we worked on the day before the test were helpful. So not before the quiz, I don't have time to do it now, but I will try to get some questions for you before we do the next test, which is our last review test. You got a quiz on Monday for this content, chapters 10 and 15, and then you'll have a test the following Monday for the rest of the content. And I will try to review a little bit with you with some practice questions for that. Okay, so that brings us up to where we are now, which is to review a little bit. So starting with uterine activity. So remember our fetal monitor strip, if you remember from Monday, and those of you guys, again, who were in clinical yesterday, certainly remember. Our monitor strip looks like this, remember? And it has a graph on the top, a graph on the bottom. The graph on the top represents fetal monitor, or the fetal heartbeat rather, and the bottom represents contractions, just like you see here. So let's talk a little bit about what you need to know about contractions. Frequency. Remember, frequency is from the beginning of one to the beginning of the next. Beginning of this one to the beginning of this one to the beginning of this one to the beginning of that one, all the way across. We usually take about a 10-minute view and make our assessment of that 10-minute view. So if we're going to count frequency here, remember, we're going to start right here. It's going to be 1 minute, 2 minutes, 3 minutes, 4 minutes. Next contraction starts here at 5 minutes. So the frequency there is 5 minutes. Duration, on the other hand, is just what it sounds like. How long did it last? How long did the contraction last? I don't think I told you this Monday, but we really don't like contractions to last more than 60 seconds. Because really, you need the baby to have that relaxation time between contractions. So a good contraction is a contraction that lasts no more than approximately 60 seconds. So this contraction, as you can see, if here's our lines for 1 minute, This contraction lasts 60 seconds, as you can see. Same thing here, 60 seconds. We'll look at some monitor strips as well in a little bit, and we'll calculate those. But you're just going to count the little blocks all the way across. Remember, on the strip there, you have the big blocks that represent 1 minute and the little tiny blocks that are 10 seconds. So that is duration. You just count those blocks. Now, so I was telling the students yesterday, and I'll tell you guys, you will see a couple strips on the quiz that you have to calculate either frequency or duration. And the choices will be really clear because even seasoned nurses, one nurse will come up with 55 seconds, another nurse will come up with 70 seconds. So within a 10 to 20 second range, you may see nurses come up with different answers. So the choices will be well spaced so that, you're off by 10 seconds and you get it wrong and you got it right because you're right on by 10 seconds. So I'll make sure that there's 30, 40 seconds between the choices so that they'll be fairly clear to you. Because again, it's everybody's interpretation when you get down to those little 10-second blocks and did it in here or did it in here. So that's understandable. Okay, strength or intensity of contractions. What kind of monitoring do I have to have in order to be able to assess intensity?
Internal.
Has to be an internal intrauterine pressure catheter, IUPC, intrauterine pressure catheter, in order to assess strength or intensity of contraction. And it is because of all the artifacts and all the things that happen as a result of having the TOCO in the belly, a heavier patient, coughing, sneezing, moving. All those things affect that. And those of you guys that have been in labor and delivery have seen those TOCOs and know that. I think it was Anthony had a patient yesterday that he says contractions look like little tiny blips until they put in the IUPC, and then all of a sudden they were peaking up in the 90s, 90 millimeters of mercury, and the little chart only goes to 100. So sometimes you think they're doing nothing by looking at the contractions. You put an IUPC in, and all of a sudden they're off the chart. And you have to literally turn their Pitocin down. Or on the other hand, if they have that little tiny basketball belly and they're real little and their contractions look like monsters and they're sitting there laughing and playing cards, again, it's because their contractions are picking up so well that they appear stronger than they are because they're so little. So it really varies in terms of the ability to assess intensity. You cannot properly assess it without using an internal monitor. Now, so when you document, you can either say A, unable to assess, or you can palpate. Put the tips of your fingers on the fundus of the uterus and feel the tightness of it, and you can say mild, moderate, or strong, mild, moderate, or strong based on palpation. And that is a subjective measurement for sure, but it is a measurement that nurses use sometimes. Resting tone is what is the pressure within the uterus when there's no contraction going on. So this area right here is where we would assess resting tone. Again, do we have to have an IUPC to assess resting tone? Yes, we cannot get a millimeter of mercury reading. Anything that requires a millimeter of mercury reading for pressure requires a IUPC because you cannot get that externally. You can't tell what's the pressure inside the uterus by feeling it. You have to have an IUPC. And then relaxation time last is how much rest does the patient get between contractions? Or the baby, patient, the two. The baby's really what we're worried about. We're worried about how the baby's tolerating labor. So how many minutes of relaxation time is the baby getting between these two contractions? 1, 2, 3, 4 minutes, right? How much relaxation time is the baby getting between contractions? That's relaxation time. Any questions about that? Because you will have a question or two where you will have to determine frequency or duration, and it may ask you what is the intensity, and you'll have to look and see in the question. Did it tell me? Is it an IUPC? Is it not? And, if it asks you about intensity, it will tell you whether it's a TOCO or whether it's an IUPC. And you may have to say whether or not you can make that assessment based on whether it's a TOCO or whether it's an intrauterine pressure catheter. Okay, let's look at these contractions right here. So we look at them here. I think we did this the other day, but the contraction starts about 10 seconds within that red line. So I'm going to go 1 minute, 2 minutes, about 3 minutes. Within 10 seconds, it'll be 3 minutes right there. So one nurse might say 2 minutes and 50 seconds. One nurse might say 3 minutes. So there is a little bit of variation there depending on what the nurse interprets. So that's why we give 10, 20 seconds at least, maybe even 30, depending on the situation, for interpretation. I would just call it 3 minutes because it's starting to go up there, but really, to me, that would be 3 minutes. If we looked at from here to here, this one starts again, really right inside the 1 minute line here. So I'm going to say 1 minute, 2 minutes, and about 10, 20 seconds. So 2 to 3 is what they've interpreted this whole strip as, which is about what I came up with too, about 2 to 3 minutes. Does that make sense? Questions? So what's the duration of these contractions? Well, this one, let's say 10, 20, 30, 40, 50 for that one. 10, 20, 30, 40, 50, 60 for that one. 10, 20, 30, 40, 50, 60 for that one. So the duration is about a minute, and the frequency are every 2 to 3. It says right here, external TOCO. So what's the intensity? Can't discern that. Can I discern resting time? No. Relaxation time, I can tell I've got 2 minutes here, right? About 2 minutes right here, and really just about 1, maybe and a half minutes, 1.5 minutes right there. From the end of one to the beginning of the other, about 1.5 minutes of resting time right there. What is a normal resting time? Do you remember from Monday? Less than 20 millimeters of mercury is a normal resting time. When it starts creeping up above 20, the uterus is not relaxing good between contractions, and we usually see that with a patient on Pitocin, of course. They've just got so much Pitocin in their system that their uterus is not coming back down to a good relaxation point.
Would you repeat that?
Yes. Resting tone of less than 20 millimeters of mercury is normal. When you see it increase, most likely to above, let's say the contractions are peaking at 60, but the resting tone is only going back down to 30. That's most likely due to Pitocin, an overstimulation of the uterus. It's just keeping the uterus from completely relaxing like it should between contractions. Something that some of the students learned yesterday, but I'm not really going to make you learn because I just think it's more than you need to know, is when you have an IUPC, how to calculate the intensity of contractions. What we do is, if we pretended this was an IUPC, let's just pretend for a minute it's an IUPC. We look at the intensity. So the intensity here it's about 70, there it's about 60, there it's about 60. So if the resting tone here, 25, 20, 15, oh gosh, it's about 5, actually 5 to 10. We take the resting tone, if the contractions are peaking at 75 here and the resting tone is 5, and the contraction is 70 millimeters of mercury, because you guys subtract your resting tone. Again, if the contraction here peaks at 60, the resting tone is 5, contraction is 55 millimeters of mercury. That's called and you add, and then you add all these numbers up at the end. That's called a Montevideo unit. You don't have to know that, but some of the students were coming back and talking about that yesterday, so I wanted to just bring it up. So what the nurse would do would count the intensity of all 3 of these contractions, add them together, come up with a number, and that tells you if you need to increase your Pitocin or not. Basically, how do you know whether to turn it up or down? Well, of course we know how to turn it up or down if they're too close together or the resting tone is too high, but how do we know if the contractions are adequate? We add up the intensity of all the numbers, the contractions in a 10-minute strip, get a total, and then you have a normal that you look at. You turn your Pitocin up or down based on that. That's called a Montevideo unit. And again, that's really more than you need to know. But I kind of want to introduce that because sometimes students will ask, well, how do you know what's too much? How do you know what's enough? That's how we calculate it. Okay, so let's switch gears to the baby. We talked about normal heart rate, which is 110 to 160, right? We know that. We'll move on. Variability is the next thing we're going to talk about. And variability, remember, is the difference of the heartbeat from one beat to the next beat to the next beat to the next beat. That's variability. Again, if my baby is healthy, they will move. And if they move, their heartbeat accelerates to accommodate for that increase in oxygen demand. So, because we don't have the ability to assess our baby's oxygenation, I can't check my baby's stat. I can't see if my baby's pink. I can't do capillary refill. all I have is to see if the baby's moving, and if the baby's moving, the heart rate should be accelerating, and if that's the case, I know I have a healthy baby. So that's what we use on a baby. So babies know if they're well or not. If they're not well, they don't move. Again, if you have COPD or you're short of breath or something keeping you from being able to get enough oxygen, you stop and you stand still and you don't move until you get some oxygen. So that's what babies do. If they're not doing well, they stop, they don't move. And a baby that's not moving, unless they're sleeping, is generally, for the most part, not doing well. So that's how we assess fetal well-being, is by assessing fetal activity. And just like you, when you run up and down the steps, your heart rate goes up. When the baby's rolling all over the place, moving, they have limited space to move in, but for them, that's their world. So that's how they move. And however much they move, their heartbeat goes up to accommodate for that. And their heartbeat changes from beat to beat to accommodate for that. That's variability. That's an assessment of fetal well-being. It actually is very reliable, very dependable in terms of assessing fetal well-being. Now, sometimes if you have minimal variability, the baby's still okay, and surprisingly, you see the baby ends up still okay. So if it's good, if variability is good, it's a really good sign. If variability is bad, it usually is a bad sign, but there may be some false negatives, but there are not false positives. Does that make sense? All right, so variability is measured by absent, minimal, moderate, or marked. 0 to 2 is absent, 0 to 2 beats of change from beat to beat, 3 to 5 beats of change from beat to beat, 6 to 25, greater than 25. Moderate is where we want to be. This is where we want to be. So I will tell you it's very difficult to look at a strip. Carol went to the fetal monitoring area yesterday where they were doing fetal monitoring all day on outpatients. And so after a morning of doing it, she started kind of getting the hang of it a little bit. But for you guys who don't do it on a daily basis, it's really hard to look at a strip and say, is that variability okay? If it's really obvious, it might be okay to you, but when it starts getting close between mild and moderate or absent and minimal, it's hard for you all to discern. So, yes.
I just wanted to mention that I posted the website that Amanda gave me to practice those on our Facebook page.
And I would highly recommend that you check that out, what she posted, because what it is it's a place where it'll pull up all kinds of fetal monitor strips, and you can look at them, you can review, and you can actually test yourself, and for decels, for variability, for heart rate. The girl who worked downstairs, I wasn't even aware. I mean, I'd heard of it, but I wasn't really aware of even the website. But go there and look at strips over and over and over again and practice. And you actually can test yourself, I think. Yeah. So I highly recommend if you're struggling with this at all, that you take a look at that.
And it tells you right away whether you got it right or wrong. I mean, there's like 5 on a page or 6 on a page, and when you click on one, it'll tell you whether you're right or wrong before you move to the next.
Great resource. So definitely check that out. Okay. So let's do one for practice. Okay. The difference between 141 and 149 is 8 beats. 149 and 160. How many beats? The difference between them? 11. 160 and 139. 39 and 148. Yeah. 148 and 155. 7. So we have a low of 7 and a high of 21. So my variability is moderate, right? Okay, let's do one more. Everybody got this? Anybody have any questions? So instead of looking at the strip and trying to determine, I'm just going to give you numbers. You're going to look at the difference from one beat to the next beat to the next beat. These are fetal heartbeats. It's if I was standing in front of the fetal monitor and watching it, instead of it coming out on the strip, I'm watching it because the beats will show up on the monitor as well. Okay. Difference of what? Here. 3. 4. What do we have here?
Five.
5. So we have 3, 5. So we have variability that is minimal. Good. That's all you do. I will try my best. In the real world, does it overlap from one to the next? Yes, all the time. I will try my best for testing purposes to keep it in a, absent, minimal, or moderate range, so that it doesn't, you're not, trying to figure out what to pick, whether to pick minimal or moderate. But in the real world, know that it does overlap a lot. So what we would do is we would look at where is it the most. Is there only one number that's in moderate and the rest is minimal? Then it's minimal. Or vice versa. So where it predominantly falls is what we would come up with, what we would put for our answer. Marked is unclear significance. We don't really understand what it means. It's the one that kind of looks like VFib a little bit. I'll come back to that slide. But this is absent. So you see there are changes. You can see that over time it does go here from 170 to 160, but from beat to beat to beat, it's 160, 159, 160, 159, 158, 150. You see how I'm saying it goes beat to beat to beat. It doesn't change more than a beat or two. This is absent variability. So you might see a baseline change, but it's going to be very gradual and very slow. The beats are going to be very close together. This is minimal, so you can see a little more movement from beat to beat, a little bit more. Moderate, 6 to 25 beats if we kind of looked at it there and marched it out, but that's kind of what you've got there. And then your marked greater than 25 beats looks like what you all may think of as VFib. If that's marked variability, just means the heartbeat's radically changing from beat to beat to beat. We don't really understand why, but it's considered an abnormal finding. Okay, so let's go back. Let's talk about if the variability is absent or minimal, what are possible causes of that?
Baby sleeping.
Sleep cycle, fetal sleep cycle. Babies sleep anywhere up to 40 minutes, usually about. So we can wait for them to wake up, or we can try to wake them up by shaking mom's belly or putting a radio next to her belly. Down in the non-stress area, they used to have this thing they called a vibroacoustic stimulator that had a vibration and a loud buzz. You put it on the mom's belly, and it literally, I got to the point where I didn't like using it because it disturbed the baby so much that, they literally were, you could tell they were going like that. It's just a loud buzz in there that they could hear. And I actually had one patient that had a big D cell after it. I think it scared the baby to death, literally, after that. Then the baby, big D cell, thought we were going to have to do an emergency C-section on the patient. It works though, but I don't know if they're even still using it, but we used to use it a lot. Just try to wake the baby up. So sleep cycle. Maternal sedation is the next one. And maternal sedation is just induced sleep because of something we gave to mom, right? So the baby's sleeping longer than normal because mom was sedated. So if my mom's sedated long term, like if she's on methadone or something like that, we may have a difficult time assessing variability. But we just have to kind of assume it's okay and know that we can't really assess it because when mom's on long term opioids, which are going to really affect the variability, right? So in that case, we just have to hope for the best. And sometimes the baby will wake up a little bit and you'll get some accelerations and some changes in the heartbeat. What's the next one? There's one other one that we can possibly blame it on. It's not hypoxia. Yeah, maternal hypoglycemia. If my mom's stomach is empty, the baby doesn't like to move much. When they come in downstairs for their outpatient ultrasound, one of the first things you would ask them, have you eaten this morning? And the best way to get the baby to move is to have them go get a pop and a candy bar. Sugar, sugar, sugar. Your sugar will get that baby moving like crazy. So maternal hypoglycemia can also keep the baby from moving and from having the variability that we would expect to see. If it's not any of those, then we suspect hypoxia or perfusion. But when you kind of run through those first things, it's not something you just, it's bad variability, oh my gosh, let's freak out. You kind of got to work through what are the possible causes. Is it the baby sleeping? Let's wait for the baby to wake up. Is my mom sedated? Do we need to feed the patient? So it's something that we can take a little bit of time. It's not an absolute emergency. If the heart rate is normal, we can kind of work through and take some time and figure out if we can get the variability to come back. So we don't just jump on it immediately and go run to the OR because the patient walks in with poor variability.
And those causes are for
minimal or absent.
Yes, minimal or absent, yes, minimal or absent. And obviously, if it's absent, we worry more than if it's minimal, by degree, it's worse. But the causes would be for minimal or absent, that's correct. So again, it's not like a ding, ding, ding emergency, like a prolonged bradycardia or something, but it's something that we're gonna look at, we're gonna watch if we can't, within a couple hours, if we can't get it to come around, we don't have anything to blame it on. Like if mom's sedated, we have to, again, we've got to say, okay, well, we're gonna have to assume that's the cause. But if we can't find any cause, then we would start being concerned. And remember I said on Monday, and I think it says in one of these slides, be especially concerned with fetal tachycardia accompanied by poor variability. I think I even have a strip of it in here. But if the heartbeat's high, above normal, it says 170, 180, and there's poor variability, that is like a double whammy. It's a real ominous sign. Okay, so that's variability. That was number 2. Number 3 are accelerations of the heartbeat. Accelerations are just magnified case of good variability. Basically, what we're saying here is the baby's heartbeat's going way up above normal, at least 15 beats up above the baseline, and we classify that as an acceleration. They are wonderful. They got jump up and down. We're happy. The baby's happy. Well, we're all happy. Accelerations are our best indicator of fetal well-being. I will write that down. Accelerations of the baby's heartbeat are our very best indicator of fetal well-being. Best thing we have to determine if my baby's okay. In a 3rd trimester pregnancy. Now, if my patient's 24 weeks and I don't have accelerations, am I worried? No, because I know my baby is immature at 24 weeks, right? 24 weeks is not 3rd trimester. So if my baby is doing well and I see accelerations of the heartbeat, and my baby's in the 3rd trimester, I'm a happy camper, but all's well. As a matter of fact, I was telling students yesterday, and this might be a good example for y'all. If a patient comes to labor and delivery and thinks they're in labor, and we check their cervix, and remember I said we get them up and tell them to go walk, and we'll check you again in 2 hours and see if you're dilated. We don't get them up to walk until we see if there are accelerations of the baby, assuming it's 3rd trimester. If the patient's in the 3rd trimester, we look for 2 accelerations in 20 minutes on the strip. And if we see those accelerations of the heartbeat, off the monitor they go. They don't have to be monitored for 45 minutes out of every hour. They can walk. We just put them back on for like 15 minutes out of the hour to check the heart rate real quick again, and then back out. They can go walk again. So it's so reassuring that we'll take them off the monitor and say, we don't need to monitor you. We're so reassured by that, by those accelerations. So the best sign of fetal well-being we have are accelerations in the heartbeat. And I will tell you, I told them yesterday, when patients come in weekly that are high risk to have, this fetal monitoring testing, if the patient has those 2 accelerations in 20 minutes, the chance of them dying within the next week of hypoxia or poor perfusion is less than 1 in 1,000. Just a little factoid there for you. The chance of them dying from poor perfusion or hypoxia within the next week is less than 1 in 1,000. Because it tells us so much that they're doing well. Now, unless something happened. Now, let's say they got kicked in the belly by somebody or in a car wreck and hit their head. Now, that would change things. But with no changes in condition, there's less than a 1 in 1,000 chance that the baby would die from poor perfusion. Because right now, the perfusion is so good that we would expect it to be the same for at least a week. Also, even in the presence of other decelerations of the heartbeat, accelerations tell us the fetus has good reserve. So even if we're seeing some other kind of decels, if they're acels as well, and I'll show you some accelerations here in a minute, we still don't think the fetus is okay. So accelerations, A+. We love them. That's the good thing that tells us our baby's okay. Here's some accelerations. So here's my baseline right here, right? My baseline is like 120 to, goes up actually to 140, really. So right here's my baseline, but acceleration. All those don't, most of them, but all of them don't quite go up by 15 beats above the baseline, but most of them do. But they're all accelerations. So that's a happy baby.
That's what you're saying, accelerations are? at least 15 beats above baseline?
Yes, and I'm gonna give you some, when we talk about non-stress tests in chapter 10, I'm gonna give you some more specific parameters, but they have to be, if our baseline's 120 to 140, they have to go up at least 15 beats above that baseline. So tachycardia is, again, fetal heart rate above 160 for at least 10 minutes or longer. And we know the prematurity of our baby will cause a high baseline, but it will not cause sustained tachycardia. It might run 160 to 170, but you're not going to see that 170 to 180 heart rate. That's way high. It might just be at the very top end of normal. If they're, they're premature, we'll be aware of that, but it doesn't cause sustained tachycardia. So what causes fetal tachycardia? Maternal stimulant use. I'm looking at that word maternal. My mom takes methamphetamine. Does it cause my mom's heart rate to go up? It's going to cause baby's heart rate to go up. And I'm not saying going up in a good way by good variability. I'm just talking about going up in full nits. So good increase in heart rate is when it does this. It changes, it varies, and it changes because the baby's moving. When it just goes up like this and stays up, that's what you see with maternal stimulant use. Because it causes mom tachycardia, causes the baby tachycardia. The kind of tachycardia we don't like, with no variability, just high heart rate and no variability with it. Maternal fever is the most common cause of tachycardia. So as soon as I see a baby's heartbeat, tachycardia, the first thing I usually do is check my mom's temp. Because I can't check my baby's temp, right? Can't do that. So I check my mom's temp, and usually if my mom's got a fever, my baby's going to get a fever too. Fetal hypoxia, again, I said, poor variability accompanied by tachycardia usually represents a baby that's not doing well. So fetal hypoxia, fetal fatigue, and remember, be especially concerned with fetal tachycardia accompanied by poor variability. What you would see was maternal stimulant use. So we want to be very concerned about tachycardia if there's also absent or minimal variability.
So with the stress of labor also?
It can.
Okay.
It absolutely can.
Because my mom yesterday, like the baby went tacky at one point for a little bit.
Yes, absolutely, and especially like if the babies are just really tired. Usually when they get really tired, it's too late, but sometimes they'll just go straight to tachycardia, which kind of tells us they're really trying to give us a warning sign. Now, if it comes back down, then whatever interventions you did must have been successful.
Yeah.
But if it goes up, then we are worried about, some kind of fetal stress, whether it's related to contractions, whether it's related to fever, infection, whatever the case may be. There's fetal tachycardia accompanied by poor variability. So you see it's running, this is 170, so it's running 170 to 175 basically. That. Only rarely does it go to 175. So it's probably more like absent variability and tachycardia. So that is a really bad combination.
So the bottom was I'm sorry.
It's okay.
I was just, the top is fetal tachycardia, the bottom.
This is the contractions down here. These are contractions. So this is the fetal tachycardia. So think of contractions as mountains. Mountain, mountain, mountain. And so why do we even need the contractions to be on the monitor strip? That's a good question. Because, well, tell me, why do we need the contractions to even be on the monitor strip? What's the importance of it?
You can see the duration
So you can see the and so you can see the correlation with the heartbeat. Because some decelerations we know we diagnose based on when they occur in relationship to the contraction, right? So earlys and lates, which we talked about Monday, we're going to talk about them again, you cannot even diagnose them without seeing contractions. So we have to have them both here to see what are these contractions causing. Contractions, remember, are stressor, right? What did I say happens during a contraction? Well, you can have fetal heart rate cells, but what happens to every baby when the contraction happens? They're holding their breath. And Anthony, the example I used, Anthony going underwater at the pool, holding his breath. So if the contraction lasts 60 seconds, probably the top half, 30 seconds of it, the baby's getting very limited oxygen. So it's kind of like turning off the oxygen spigot for, half the contraction at least. And again, a baby will do fine for a while. But how long can you do it? Every 3 minutes, every 3 minutes, every 3 minutes without getting tired. Depends on how much reserve your baby has and how healthy your baby is. A baby whose mom's a smoker, a baby whose mom has had poor nutrition, maybe who has hypertension, doesn't have a lot of reserve. They're already suffering from some placental calcifications. They're already got limited oxygen available anyway. Now we add the stress of labor on top of it, contraction after contraction after contraction after contraction. What's going to happen to them over time? They're going to wear down, right? Just like you would wear down. Eventually, your stats would start to drop. You start to feel dizzy. You would have to be able to get up, move around. So your baby is going to start feeling the effects of that too. If we were to check the baby, if we were able to check the baby's blood gas, and there is a way to do that, believe it or not, we don't do it much anymore. There is a way to do it. Then the baby would be acidotic. We would find an acidotic baby. So labor is a stressor, and how well your baby does depends on how good they're doing coming into it. What do they have going on with them? What kind of stressors are they carrying with them into labor? If my mom's healthy, she eats well, she doesn't smoke, she does everything she can to be healthy, then you probably have a baby that can tolerate a lot. But if you got a mom that's using drugs, that's not eating and drinking Mountain Dew all day and smoking, that baby doesn't have much extra to start with. So you put labor on top of them, and it's just too much. Okay, so that brings us to bradycardia and deceleration. So by definition of your textbook, bradycardia, by definition, is a fetal heart below 110 for 10 minutes or longer. I will tell you that usually if it just bottoms out, the fetal heart just bottoms out. Usually it's 5-6 minutes we're in the OR to do a C-section, so we never wait 10 minutes. So that's what we'll go by. That's what your textbook says. So we'll go by what's on the PowerPoint. But just FYI, we never wait that long. If it's just a prolonged bradycardia, and that means the heartbeat just goes like this. So you're really less likely to see that than you're likely to see a pattern of types of deceleration. Not to say you can't see a prolonged bradycardia, but it's not as common as specific types of deceleration. So if we do see it, there's a specific thing that we do called intrauterine resuscitation that we use to resolve bradycardia or some certain kinds of decelerations that we'll review in a minute. There's 3 things that are called intrauterine resuscitation. Left side, in this order. Left side, oxygen at 10 liters per mask, increase IV fluids to increase maternal blood volume / cardiac output. So left side first. If that doesn't work, we can try right side, but always left first. O2 at 10 liters per mask, increase IV fluids to increase cardiac output, and you must be using lactated ringers for that to be effective. Because what are we trying to do? We're trying to pump up intravascular volume. What does normal saline do? It pumps up volume everywhere, and it leaks or diffuses out into the tissue and will cause edema as well. We don't need that. We need blood to stay in the vascular space. The only IV fluid that will stay in the vascular space for a period of time is lactated ringers. That's why we use that specifically. Here's a fetal bradycardia. What really I would like to see, and there, if you look back in chapter 16, there's a slide where it talks about cord prolapse, and there's a strip where it shows it's 130, and it just goes like that. Also, if you go to that website and you just want to type in prolonged bradycardia, you'll see where it just bottoms out. And this is where it's, this is the bradycardia that's already down there, but if it starts up here at 150, then it just goes like that. That's called a prolonged bradycardia. Every now and then we'll get a patient that it goes down like that, it stays down 3 minutes, and we do all these things, flip them, oxygen, all this stuff, and then it just pops back up. And we have no explanation for it. Sometimes it does that. But if it does it usually for more than 5 minutes, we don't worry about what's happening. We just take it to the OR, do an emergency C-section. That's why I said, per your textbook, they say 10 minutes to diagnose it as a bradycardia. We say we don't wait 10 minutes. Too long to wait. Okay, that brings us to veal chop. Since the slide's not going to be here, I'm going to write it over here again. We can refer back to it. She is for variable. Early. Okay. So variables first. variables are caused by what? What causes variable
Cord
decel?
compression.
Cord compression, umbilical cord compression. So variables mean the cord's being squeezed. I'm out in my yard, I'm watering my flowers, and all of a sudden, the water stops. No water. So I turn around, and my cord's all kinked behind me. Ever happened to you? How do you fix it? You unkink your cord, right? You turn around, you unkink your cord. That's what we're trying to do with the umbilical cord. We can't get in there and unkink it. So what do we have to do? Move my patient. Left side, right side. She doesn't have an epidural, knee, chest, out of bed, in bed. Whatever we can do to move her to get the cord to move is what we're going to try to do. If she has an epidural, obviously, we're more limited on how we can move her, but we're still going to move her. Left side, right side, left side, right side. We're going to try to move that cord. Because cord compression means my hose is kinked. I've got to unkink my hose. There's a picture, I think, on one of the PowerPoints where it shows the cord up between the baby's knee and calf. The baby bends his knee and the cord gets squeezed. I've seen ultrasounds with babies having the cord in their hand, literally doing this. So that can happen. It could be around their neck, and just, when they get in a certain position, it gets tight. There was a C-section yesterday that had a true knot in the cord, literally a knot. So the baby literally had to loop it and swim through it to get it to knot like that. So that probably happened months ago when the baby was very small and could still swim through it. And then it just got pulled tight. So fortunately, that baby did well yesterday, and it didn't cause any problems, but I've seen dead babies from true knots in the cord as well. It's pretty rare. I was telling them I've probably seen I've not even seen 20. I've probably seen 12 to 16 in my whole career. And 3 or 4 of them ended up with fetal demise as dead babies because the cord pulled so tight that it, impaired blood flow. So that is a sort of a variable in a way, but it's caused by a cord being tied in a knot. And now that it would be very hard to unkink. But if it's just being kinked by, a knee or a shoulder or a fetal movement, we could try to move the baby. And remember I said, when are these variables more likely to be worse? Before the water's broken or after? After. Because the buoyancy of the water is going to cause the cord to float and do this, right? So you get the water out, the amniotic fluid's gone, now there's no cushion for that cord. So now when the baby rolls on it, there's no buoyancy, and it just gets compressed and smashed. You see variable deceleration. Variable decelerations are visually abrupt, V-shaped, W-shaped. The longer they last, the more we worry. So are they ominous? Only if they become severe. If they stay mild and occasional, we don't worry. If they become severe and long and last long, we do worry. So it really just depends on the severity of them. And again, what's my intervention? Move the patient. So it doesn't necessarily mean we have to move to the left side in this case. We just need to move them. They might already be on the left side. So now we need to just change the position to try to get the cord to move. Remember, my hose is kinked. I have to unkink my hose. Variables right here. V or W shaped. Visually abrupt, rapid return to baseline. They are not connected to contractions usually, unless there's something that's happening during the contraction, like maybe when the contraction happens, that's when the shoulder gets up against it. So you might possibly see a case where you would see variables during contraction, but there's not a pattern there that we look for. Does that make sense? If you see them during a contraction, the something about the tightening is what's causing the compression, but we don't necessarily see them during contractions. Usually they're not associated with anything as far as contraction patterns. It's a variable relationship to contraction. We don't have to see them before or after during contraction. They might be, they might not be, they're just whenever they happen. Whenever the cord happens to get compressed. So you can see here, this is the picture I was talking about. See the arrows here? Here's the cord, here's the back of the leg, and the calf, and every time the baby puts his foot down, he's smashing the cord right there. So every time he does that, you're going to see a variable over here. Again, variable accelerations, again, these happen to be right about when the contractions occur. It's just an incidental thing. Don't get wrapped up in, is it during the contraction or not? Because 9 times out of 10, they're not associated with contractions. But they're V, W-shaped, come right back up. Okay. Now, on the other hand, early decelerations are caused by what? Fetal head compression. So head compression, or H in CHOP, head compression. They're more rounded looking. They're not V-shaped usually. They're more U-shaped and rounded looking. These are one kind that we must be able to see contractions to be able to diagnose because they're associated with contractions. There are two kinds of decels that are associated with contractions, early and late. So there, it's right there in the name. It's the timing, early and late. Now, earlies aren't before contractions. I don't know why they're called earlies. I don't know why they're not called with, but they're called early. Early decelerations are caused by fetal head compression. They come with contractions. It's the head being squeezed in utero, and it causes a vagal response to the fetal head. So you get a little drop in heartbeat related to that vagal response. It is not reassuring. It is not non-reassuring. It is neither. It just happens because the head's being squeezed. It's not a bad sign. It's not a good sign. So when you see something that's not bad, that's not good, usually if you see it on HESI or NCLEX, your response is going to be usually to document the findings. That's what the kind of the response you're looking for. But I want to add to that, we also expect to see rapid progress in labor when we see this. So if I see early deceleration, I really need to check my patient and make sure if she was 3 an hour ago, she's not 9 now or 10. Because usually it means the patient's progressing quickly, especially in a multip who's had multiple babies. If you're early, you better get ready. If they're accompanied by no progress, so she was 3 an hour ago, and she's still 3, and she's still 3, and she's still 3, then I suspect, what do I suspect might be going on? Cephalopelvic disproportion. The head and the pelvis aren't driving. One's too big and one's too small. So if, in spite of all that squeezing of the head's not descending, there must be something going on to keep it from descending. That's my suspicion. Does that mean we run to the OR right then and do a C-section? No. It just plants a little seed in our head that, within a couple hours, if we still see no change, we need to start thinking about what's going on here because we're not seeing a lot of progress. So our interventions here then are document the findings because it's not reassuring, it's not non-reassuring, it's just something that happens, and assess labor progress. So those are the answers that you would be looking for. I've seen a lot of HESI type questions that will just, instead of saying look for labor progress, which is kind of what I would look for, it'll say document the findings because it's not considered to be an abnormal occurrence. Anytime you have a question and it's a normal occurrence or it's not ominous, then usually your answer choice is going to be document the findings, which means it's not abnormal. So earlies, look at something here. They're more U-shaped. You can see right here. If the peak of my contractions here, the peak of the drop, that's going to be right here. So they're, peak to peak, so to speak. This peak's going down, this peak's going up, but peak to peak. Meet, and they meet. See where they're meeting? And still, after all these years of doing this, I still take a pencil or a ruler or something and I hold them up there. Are they earlies versus are they late? These are earlies because they're right with the contraction. What's the relationship to the peak of the contraction? It's right with. And what the arrow is showing you is that by the end of the contraction, it's recovered back up to its baseline. In the contraction here, it's recovered back up right there. But the peak of the drop here equals the peak of the peak there. The peak of the contraction there, rather. Okay, does that make sense to everybody? Questions?
So either it's going to be before or at the peak.
Yes.
For early.
Well, it really doesn't come much before. It usually starts as the contraction starts, and the peak of the drop, the most significant part of the drop equals the peak of the contraction. So those are earlies. Okay. And earlies are caused by what? Tell me what causes them.
Head compression.
Head compression. It is a vagal response to fetal head compression, right? Another picture of earlies, so you can see right here, if I have my pencil, pen, whatever, right there together. I have my body away. There, right there. But I always take a pencil or pen still and put it right up to it so I can prove to myself that it is equal peak to peak. Peak to peak. Okay. Now the last one is the big daddy bad guy. This is the one that nobody likes. Late deceleration. Always ominous, always abnormal, always. Okay to be early, but don't be late. So late acceleration, oh, we skipped acceleration. So accelerations are?
Okay.
Okay, we love them. Okay. When I say accelerations, I'm a happy camper. Everybody's happy. I'm going to have a good day today. Accelerations, the baby's heartbeat. I'm going to have a good day at work today. Then when we see late, we know that's caused by what? Placental insufficiency. Or poor perfusion, or for some reason my baby is not getting enough oxygen, and I've got to figure out why. Because it's probably not going to be obvious. It might be obvious, but oftentimes it's not. So, on the other hand, like I said, I see accelerations, I know I'm going to have a good day. I see late accelerations, I know I'm going to have a bad day. I'm going to have a day sitting in my patient's room worrying all day. We'll get some resolution up, and we'll figure out why they're happening. The cause is uteroplacental insufficiency. The question is, what's causing the uteroplacental insufficiency? Why is it happening? That's the nurse's job to figure that out, and if he or she can, to fix it. So possible causes. Interestingly enough, it's either hypertension or hypotension. Either one will cause it. So what's happening with hypertension that causes placental insufficiency? Calcifications of the placenta, vasoconstriction. So hypertension is going to be a little bit more of a chronic condition. So it's going to be harder to fix, right? It's harder to fix a chronic condition that's been going on. My patient's been smoking all of her pregnancy. She has severe preeclampsia. She's been using stimulants her whole pregnancy. That's going to be hard for me to fix because it just, the lates are going to start happening at whatever point the baby finally has had it and is just not getting enough oxygen. Whenever the baby kind of moves over into that, I'm doing okay, I'm not doing okay. When the baby becomes acidotic, finally, you'll start seeing lates. So it's going to be hard to fix because I know, if I know that it's going to be from hypertension. So that's the patient that has lates and you can't make them stop because it's from a chronic thing. And a lot of times we end up having to do a C-section because we can't, nothing we do, none of our interventions are effective. So we end up having to do a C-section, get the baby out, and then deal with the baby. So hypertension is going to be more of a chronic issue, but will absolutely cause lates. And we just talked about why. Hypotension, on the other hand, is also going to be a problem. Why is hypotension a problem? What's going on with hypotension? But why? What's causing it? What did you say, Kim? Yes. Yes, baby's not getting enough oxygen because the blood pressure's low, the cardiac output is low. If my blood pressure's low, is my cardiac output low? Yes. If my cardiac output's low, is my uterine blood flow low? Yes. If my uterine blood flow is low, is my placental perfusion low? Yes. Does that make sense? So it's just a one step after another. Low cardiac output, low uterine in blood flow, low placental perfusion. So what are things that I see in pregnancy, in labor especially, that are likely to cause hypotension? What's the biggest thing? Epidural. I can't tell you how many times we see epidural-induced late deceleration because of a hypotensive episode that happens right after. Remember, when you get an epidural, it causes systemic vasodilation. So when I have systemic vasodilation, my pipes just get way bigger, so what happens to the pressure? Bottoms out, right? When my pressure bottoms out, my cardiac output drops, my uterine perfusion drops, and then my placental perfusion drops. So I got to fix that. So usually when you do an epidural, we do some preventive things, like they'll give them a fluid bolus before they do the epidural, give them like a liter bolus to start out with, of lactated ringers, and then they'll keep running it. In addition, if their blood pressure gets low afterwards, they'll give them vasoconstrictors, ephedrine, phenylephrine. They'll give you standing orders. If the blood pressure goes below this, you give ephedrine or phenylephrine. So we'll give that IV to keep the pressure up, literally. And we'll keep running fluids in and keep running fluids in. That's why that test question that you had Monday about 3 hours after an epidural, vitals are stable, labor's progressing, what's next? My patient's bladder, right? Because she's been getting all that fluid for 3 hours. And if the question's telling you everything else is okay, your bladder's the next assessment to make. So we give them a ton of fluid. Some patients will get 4 liters of fluid before they deliver, if not more. Because of their epidural, we can't keep their pressure up. So hypotension from epidural is the most frequent cause of hypotension that we have to treat. But we can also have hypotension. Let's say my patient, something happens and she hemorrhages. She has a placenta previa and she starts hemorrhaging. And she loses 2 liters of blood. So really, we'd be wanting to get that baby out really quickly. But if she comes in from home and she's lost 2 liters of blood, would I be surprised to see late B cells on the strip? No, because she's lost 2 liters of blood. She's very hypotensive because of blood loss. So I might see late from that. Does that make sense to everybody? Okay. So hypotension, poor cardiac output leads to late B cells. Anything else that decreases cardiac output as well, like put my patient flat on their back. I have seen late decelerations induced many times by a patient laying flat on their back. And usually they'll tell you, they'll say, oh, gosh, I'm hot, I'm sweaty, I'm dizzy, I feel like I'm about to pass out, and they're just laying there. They say they're about to pass out. They're flat on their back. So we've reduced their cardiac output by about 40 to 50% by putting them flat on their back. We've squeezed that vena cava like this, so therefore all the blood from here down is staying down there. Is that going to reduce cardiac output? For sure, yeah. So that's going to induce lates too. And miraculously, you put them on their side, you give them some fluids, and it all recovers, usually. It all pops back to normal. So anything that decreases cardiac output will decrease placental perfusion, will theoretically cause late B cells. Last but not least, uterine hyperstimulation. Your textbook calls it tachysystole. I've never heard it called that in OB ever, but that's what your book calls it. So if you see the term tachysystole, it means too many contractions. Uterine hyperstimulation, too many contractions, not enough relaxation time, because we know relaxation time should be how long? 1 minute between each contraction for adequate relaxation time, right? So if I have too many contractions, then I know that that can cause late decelerations, because remember, my baby is holding its breath. Every time they're having a contraction, holding its breath. Over time, the baby's going to wear down. When the baby wears down enough and becomes acidotic, you're going to see late D cells. How do we fix uterine hyperstimulation? If they're on PIT, we got to turn the PIT down. 9 times out of 10, it will be caused by Pitocin. Does your body do that to you? Usually not. Now, if you have some sort of something going on and you have uterine hyperstimulation spontaneously without Pitocin, we can literally give you a medicine to stop your contraction. It would be a medicine that we would use for preterm labor, but we can do that if we have to. Problem is, it's going to knock out your whole labor too. So, docs don't like to do that because, it kind of knocks out the whole labor, if it's a spontaneous labor. But it will work. So the key is late decelerations. If they're from too many contractions, we've got to stop those contractions. And usually they'll go away when you stop the contraction, interestingly enough. So when you see late decelerations, the first thing you do is you do those 3 because this is a bad thing too, just like the prolonged decel is a bad thing, this is a bad thing. You do those 3 intrauterine resuscitation actions, which is left side, oxygen, IV fluids, and then you start looking for a cause. Is it the blood pressure? Is it the positioning of the patient? Is it the contractions? What is causing it? Is there anything that's changing cardiac output that I can find? Is it the blood pressure? Is it hyperstimulation? And then, whatever your interventions do stop it, great. If they don't stop the lates, either way, then that's when you call the doc and say, here's what's happened, here's what I've done. They stopped or they haven't stopped. If they stopped, yay, great, here's what I did and they stopped. Or if they haven't stopped, I'm sorry, doc, I've done everything I can do. Now you need to come in and do something. So when we have a situation, we do all independent nursing interventions that we can do on our own or that we have a protocol for. Then we call the doc and report what's happened. And then we either fixed it or we haven't fixed it. And usually when we haven't fixed it, that's when the doctor has to get involved. So if you're asked on a test question, and one of your choices is call the doctor, you look at that question and you say, A, have I done every assessment I can do? B, have I done every intervention I can do? Just like if you walk in a patient's room and their foot's blue, they had surgery on their foot, their foot's blue, you don't run to the desk and say, oh my gosh, their foot's blue. You check the pulses, you elevate the foot, you see if it's cold or warm, you see if they're having pain. You do all those assessments and see if you can figure out what's going on, or see if you can, get, and maybe they said, oh, I just went to the bathroom. So then you wait 10 minutes and see if it gets better. So you do what you can do, and then you call the doctor and you say, what I did worked, what I did didn't work. But here's what's going on. Okay, questions about late deceleration, what to do. Tocolysis, okay, what's lysis mean? Lysis means to stop something. Toco means contraction. To stop contraction. Lysis of contraction. So late decelerations, we're going to do intrauterine resuscitation, look for a cause, do any independent nursing interventions we can do, and then call the doctor. In that order. Okay to be early, don't be late. So prolonged decels and late decelerations are two really bad things that we have to deal with. Okay, here's some lates. Again, if we take our pencil, okay, look at the arrow. This is the peak of the contraction. Now, where's my onset of my decel? Is it after? It is, right? Because it starts after the peak of the contraction. Here's my peak of my contraction. Where's the decel? After. It's after. Here's my contraction. Where's the peak? After. So you see a uniform, usually a U-shaped. It looks a lot like early. So sometimes people are like, is it early or is it late? And you'll have nurses even arguing about it sometimes. But really, to me, it's really clear. If you put your pencil or put a ruler there, go up, see where's the peak at. If it's not peak to peak, it's late. So I don't expect you guys to be experts at identifying strips because you haven't seen enough to be experts. I'm more about asking you what to do in this situation. The patients have it late, what should you do first? The patients have it late, what is the cause? So probably the majority of the strips that you see, and you won't have a lot of strips, you might, out of 25 questions, you'll have 3 or 4 at the most. And those will probably be more of contraction interpretation than strip interpretation. I probably will ask you more about, what's the duration, what's the intensity. But these, it's just something that you learn over time how to do. You guys are not quite there yet, and it's probably not a good expectation for me to have you all just identify strips. Because like I said, even seasoned nurses will argue about, is it late, is it early? So don't get freaked out about trying to identify strips. Spend your time studying what to do about it and what's causing it, instead of eyeballing it to try to figure out what you see. Okay? Again, late deceleration, these are a little more obvious. But again, if the peak of the contraction here, you can clearly see where the late is. This is a real strip right here. Peak of the contractions here, you can see the decel over here, right? Peak of the contractions here, decel over there. If I go up, you clearly see it comes after the peak of the contraction. That's uterine tachysystole or hyperstimulation. Too many contractions. Look here. I mean, this is a blurry strip, but I love the contraction pattern because your patients get here. They don't even have a minute. They've really got maybe 20, 30 seconds of rest. Look at it. Too many contractions. You need to do something about that quickly. And there's these real weird decels up here. I suspect that they're probably late, but contractions are coming so fast it's almost hard to tell. But that's an ugly looking strip with those contractions. Well, this is more of a prolonged, this might be an art. Some people might call this a prolonged decel. Some people might call it a late. If you look, it starts after the contraction and it does come back up. Another contraction, it drops. I think there could probably be some argument there about is it a prolonged decel, is it late? I would say it's a late because you see how it's recovering. It's not staying down. It's coming back up until there's another contraction and then it drops again and then it's coming back up again. So your book called it a prolonged decel. I kind of disagree. I think it's a late. See how, all experts even disagree? Okay, so again, early decel, head compression, late, uteroplacental insufficiency, variable cord compression. Just a little illustration. All right, any questions about that? I know we spent the first hour of class reviewing it, but I felt like we went through it so fast that maybe everybody didn't grasp it, and so I wanted to go back through it because I want you to have a good understanding of what it is that you need to know and what's the need to know. This is where we stopped the other day. So at the desk at labor and delivery, you may have seen if you've been there that they've got central monitoring at the desk where you can see what's going on with all the patients at the desk. They do not have a monitor tech per se like they have in cardiac, but usually if you're not at the desk, you're in your patient's room. So for the most part, they feel like it's not necessary. Most nurses are either at the desk or in the room. But if you have two patients, you can actually pull up your patient next door or wherever your patient is. You can pull up their strip. If you're in this room, you can pull up their strip in your room so you can keep an eye on both of them at the same time, which is very nice. Remote access. There are some hospitals to where the doctors can actually see the strips in their office. They've got it ran so, like down in, I don't know how they do this, but down in the outpatient area, they've got it situated where they can pull up the labor and delivery strips from down there in the first floor. I'm not sure how they do that. But as far as I know, none of the doctors at our hospital can pull the strips up from their office, but I've seen that ability to do that in some places. So EFM is electronic fetal monitoring. If you wonder what those abbreviations are for, that's what's on that thing that Carol posted. EFM, electronic fetal monitoring. So pattern recognition, just kind of as an overview. First, you evaluate whether what you're seeing is normal or abnormal. Is it normal or is it abnormal? If it's normal, great. If it's abnormal, what is the likely cause? And then the next thing we want to look at is anticipate the time until birth. Very important as it makes a difference in what you might do. So if I'm seeing severe variables, and they're getting bad, but my patient is pushing, would it, she's going to deliver in the next 20, 30 minutes, I probably can barely do a C-section that fast. I could if I wanted to really run and put her to sleep, but it's probably just as well just to get the baby out. Now, if she's 2 centimeters and having severe variables, that's a different story, right? So you look at where your patient's at, how close they are to birth, makes a difference in how we respond. Again, if my patient's 1 to 2 centimeters and she's having late, before she gets her epidural, I know it's going to be a long day. And so that patient usually rarely makes it to the end of the day because for some reason the baby's not tolerating things well, and everything we do is going to cause the baby to respond badly. So that baby has no reserve. It's not going to tolerate much of anything. And 9 times out of 10, we're going to end up doing a C-section just because the baby's going to force our hand. So anticipate the time until birth, and it will certainly make a difference in how you respond. If my lates don't start, or my variables don't start to my patient, again, it's 9 centimeters, we might be able to eke it out and get the baby out faster. So anticipate the time till birth, and then determine if intervention is needed, and if you need to intervene, intervene. So with variable D cells, do we need to intervene? What do we do for variable D cells? We reposition. Yeah, there is an intervention to be done if we were repositioning our patient. Early D cells, do we need to intervene? No. I mean, we might assess to make sure we're ready in case the patient has a baby, but do we need to do anything about it? No, because it's not bad, it's not good, it's needed. Late deceleration, do we need to intervene? Absolutely. We've got to figure out what's going on. Prolonged D cells, do we need to intervene? Yes, quickly, because this baby's going, down, down, down. So absolutely, really the only one that we don't have to intervene at all is early. And when I say we don't have to intervene, I might make an assessment of how close the patient is to birth, but I don't have to do any interventions to try to change it. Additional methods of assessment. We can try to, remember I said we can try to wake the baby up if there's poor variability and we think the baby's sleeping. Vibroacoustic stimulator, I mentioned already. Fetal scalp stim. If you do an exam, you can kind of, you can feel the top of the baby's head, you can kind of tickle the baby's head, and that will usually wake them up. It'll usually cause all of a sudden the baby start moving and having accelerations. So you can do that. And remember I said there's a way to find out if the baby's acidotic in utero? You don't see it done much anymore, but if the patient's dilated at least 5 to 6 centimeters, so, if we do an exam, you can literally see about, maybe as much as the head, the cervix dilated about that much. You can actually put this little cone inside the vagina so you can see the baby's head. It has a little light on it. And you take a little lancet, not a lancet, because it's more of a flat razor thing, on the end of a stick, and you go in and you puncture the baby's head and get a little tiny tube of blood. I mean, all this through this long cone. It's very hard to do. And you run it to the ABG lab. and you get, all you can get from it is a pH, but you can get a pH. So that at least can tell you if your baby's acidotic or not. It's called a fetal scalp blood sampling, scalp pH. I haven't seen it done in a long time. I don't even know if they still do it, but it can be done if they're concerned about should we let patients have a late, should we let labor go on, should we do a C-section? If it comes back that the baby's acidotic, they'll do a C-section. Can be done. And then amnio infusion is something that I think Anthony saw yesterday. His patient was having, was it your patient? No, it was Breeze. It was Breeze, I'm sorry. It's Breeze's patient. She was having lots of variables and didn't have a lot of amniotic fluid. So remember I said if there's less fluid there, the variables are worse. So they actually took a bag of normal saline, hooked it into the intrauterine pressure catheter, and put fluid back into her uterus via that intrauterine pressure catheter, trying to provide some buoyancy to that cord. She was revoked from delivery, like 3 centimeters or something like that, 3, 4, something like that. And so it's going to be a long time before birth. So to do an intervention, they just tried to put some amniotic fluid back in to encourage some buoyancy around the cord to help prevent those variables so she could get through her labor. So that's called an amnio infusion. I'm not going to test you on that. I just kind of want you to be aware of what it was. And then tocolytic therapy, like your patients have lates and we need to stop their contractions. I mentioned a minute ago, we could give them something to stop their contractions. Tocolysis to stop contractions. We need to stop contractions if our patient was having lates and they were having too many contractions and we couldn't make them stop. So those are some other additional interventions that are definitely more advanced. Fetal tachycardia is most commonly seen with what?
Fever.
Yes, that is correct. That is correct. Okay, take a break and then we'll start checking.
Yeah. I was just trying to get it again. She's been looking at the animal shelter. It's literally every single freaking day. She's like, oh my god, she just texted me. It's like, go look at the animal shelter. No, I don't want another dog. I don't know how many times I gotta tell you.
I think I actually wrote down.
Oh my God.
Meeting with Kendall, I was sitting here and I'm like, fuck.
They were Harley and Kristen were talking about it when we came in, and then certain groups, I guess Miss Hackney's group, if you're scheduling with her, that meeting's today.
I need to do with
And
her
then,
too.
I don't know who the audio was. Nobody's told me. How do you know?
They'll tell you.
Oh,
They'll
nobody's
tell
told
you.
me.
Because whenever I was sitting here going over tests yesterday, Dr. Sayer told me.
Well, nobody's told me.
You're probably with her too. If Hackney didn't have you on hers, Sayer said that she sent out an email too.
Yeah, because Harley's there, and she said she knew, so I must be her.
FEM. So
Oh,
I just changed it. Yeah.
And then,
gosh.
I just wrote it right there. Oh, okay. Thanks. Sure. I just told her, I said, I think we should because somebody might not have Facebook.
Oh, yes.
Yes, I wrote it up there.
Let's see.
Thank you.
Ms. Hackney's got a list of what she needed to see. And I don't know if Dr. Sarah did hers or not. I have the middle 9 of the alphabet. Am I yours? You're mine. I'm yours. I'm yours and you're mine.
yeah, I assume.
Yeah, we can do it today. For anybody who wants to, it's not urgent. But what we'll do is, what you have to have is, I'll say this again whenever it gets back. You have to have the password that you use to get into My Bridge. And we can go in and register you if you want. We can do it after class if anybody wants to. If you want to wait till Monday, it's nothing urgent because all the I should need to be registering you all for is nursing. Yeah. But anybody who wants to do it today, and I'll read off my list. I can do it after class. As long as you've got that password. All right, why is it not working? Oh, it's working now. I don't know what I did to fix it, but I fixed it.
time to do Wordle. They just
I remember that.
Oh, what one is he? Oh. Oh, wait, no, I did an Excel file for it. I know. I got a whole degree in Excel. Shut up. Nobody asked